Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a wonderful week and I'm glad you could join us. So this week's case is a 91-year-old female that presents with intermittent palpitations. Her presenting EKG is shown here. Now before we get started, let's review the approach we've been using to interpret EKGs. So notice we have the patient's clinical presentation, then the EKG below it. On the right side of the screen, you'll see a list of different areas of the EKG that we'll go through before making our final interpretation. Now first, notice that there's the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And if it's irregular, is it regularly irregular or irregularly irregular? Next, we look at the heart rate, okay? And in this case, we simply want to determine the rate of the rhythm. Then we'll look at the rhythm origin. That is, where's the rhythm actually starting from within the heart? Then we have to determine the ventricular or QRS axis, which could help us with our differential diagnosis. And then there's the atrial, atrioventricular, and intraventricular conduction, looking at if conduction is normal or abnormal in any area of the heart. Then we'll move on to the waveforms, which would include all the waves, segments, and intervals. And lastly, anything else, meaning is there anything else that we've missed or still need to mention, such as abnormal R-wave progression or a transitional zone in the precordial leads. Okay, so after that, we'll use all this information that we've gathered to make a final interpretation of the EKG. Now I want to pause the video and I want you to take a few minutes to go through the EKG yourself. Try to answer different areas of this, okay? And then when you're ready, start the video and we'll go through it together. All right, so our 91-year-old female that presents with intermittent palpitations in this EKG. So now let's walk through it. All right, so first we're going to look at the regularity of the rhythm. So on first impression of this EKG, you probably notice that the rhythm appears quite regular, except for a premature complex that we'll talk about later. Therefore, we would technically call this an irregular rhythm, and because there is regularity to the overall complexes, we call this a regularly irregular rhythm. Okay, so let's look at that now. Okay, so this is a regularly irregular rhythm. Okay. All right, so why is that? Remember, when we deal with regularities, we're looking at what is the most often the R to R interval, okay? And why do we use the R to R interval? Okay, we use it because the QRS complexes tend to show the greatest potential on the EKG, okay? You could do this with the P to P interval, which is from one P wave to the next, but we'll use the R to R interval here, okay? So remember, the R wave is the first positive deflection after a P wave, okay? So this is an R wave here. Here we're looking at the V5, okay? So this is our R to R interval from one R wave to the next, okay? And we're looking, is that duration between those R to R waves the same throughout, okay? Meaning, is the next R to R interval the same as the one that precedes it, okay? So from one R wave to the next, all right? And then we go from this to the next one, from one R wave to the one that follows it, and then throughout this EKG, okay? And you would see that if you use calipers or use the piece of paper to measure these R to R intervals, you'd see that they're pretty much the same. The only thing that we see different is that when we have this complex here that is present, okay? So you can see that, and it's coming a little earlier than we would expect, but then the next one comes where we would expect it, meaning from this R wave to the one that comes after, that's actually two R to R intervals. And we'll see that's what's called a compensatory pause, okay? But everything that comes after this is, again, the same R to R interval afterwards. So because this is an irregular rhythm, but has regularity to it, we call this a regularly irregular rhythm, okay? Hopefully that makes sense. So what did you get for the heart rate? Well, there's a couple ways we can calculate it normally if we have a completely regular rhythm. But because we have that premature complex, we will use one way because this is technically irregular, okay? So what we'll do is count the number of complexes going across the EKG, multiply that number by 6 to get an estimate of the ventricular rate. And then because we know that the standard EKG represents 10 seconds in total duration, okay? So let's go through that now. All right, so I'll erase this so it's cleared up, okay, and there's no confusion. So remember, the standard EKG from the beginning, all right, so from this point all the way to the end represents 10 seconds, okay? And if you multiply 10 seconds by 6, that gives you 60 seconds, which is 1 minute, okay? So what we said is if we count the complexes going across, which we'll do now, so 1, 2, 3, and notice we're counting the ventricular complexes, okay? This is 4, 5, 6, 7, 8, 9, 10, we'll count that premature complex there, 11, 12, 13, okay? So we said we would take that number, 13, multiply by 6, okay, because this is 10 seconds and we want in beats per minute. So 13 times 6, what does that give you? 78 beats per minute, okay? So that's a good estimate of the rate, and the actual rate here was 79 beats per minute. So we'll just write that up here. We did 13 times 6, which was 78 beats per minute. The actual heart rate that was calculated by the machine was 79 beats per minute. So you can see that's a very close approximation, okay? So we'll erase this here, but hopefully that makes sense. And that's the ventricular rate we found because we used the ventricular complexes, the QRS complexes, to calculate the rate, all right? So now to the rhythm origin. Well, we see that we have narrow QRS complexes, so it must be supraventricular in origin, that is originating from above the ventricles. We can also make out clearly defined similar shaped P waves, all right? So what we have to ask ourselves, are we dealing with sinus rhythm? Okay, so let's see. How do we know if we are dealing with sinus rhythm? So first of all, what is sinus rhythm? Remember, if we have our box diagram of our heart, okay, this is our right atrium, this is our left atrium, our right ventricle and left ventricle. Where does the sinus node sit? Well, it sits up here in the right atrium, near the superior vena cava, okay, and then we have these internodal pathways, okay, that comes to a AV node. Remember, we have the Bachmann bundle that comes and depolarizes the left atrium. From the AV node, we have a His bundle that then bifurcates into a right bundle branch that innervates the right ventricle. And then we have this left bundle branch that splits off into two subdivisions, the left anterior fascicle and the left posterior fascicle, okay? And those innervate the left ventricle. Now, both those fascicles and the right bundle branch then go to the ventricular Purkinje fibers that innervate the cardiomyocytes, and that's how the depolarization wave spreads. So when we talk about sinus rhythm, that means that we're originating from here, the sinoatrial or sinus node. And notice that our conduction pathway heads this way, okay, towards our AV node, which is here, all right? So if we were to superimpose the right atrium on this, okay, so imagine this is our right atrium here that we're putting on this vector here, okay, our sinus node again sitting up in this area here, and the vector heading in this direction, you would see that the normal axis of, or the normal P wave axis, which represents the atrial depolarization, is between 0 degrees, okay, and actually about here, positive 75 degrees. So this is where that normal axis, that P wave axis, heads in that direction, okay? And that's where we would want to see the sinus P waves heading in that direction, okay, coming from that sinus node. And what you'll want to do is now put where those leads are placed. So remember, lead 1 is here at 0 degrees, okay? And then you have here positive 90 degrees where the lead AVF, the positive end sits, okay? And then this would be plus or minus 180 degrees, and this is negative degrees. And we'll talk about that when we talk about ventricular access next, okay? So because that depolarization waves heading in this direction towards lead 1, we want to see positive upright P waves in lead 1, okay? We may see them in AVF. Lead 2 sits here at positive 60 degrees. And then remember those leads in the horizontal plane, those leftward leads, which are V4, V5, and V6, okay? Again, the impulse heading in that direction, so we should see upright P waves in those leads as well. Now remember, AVR sits here, okay, and because the impulse is heading away from it, we should see negative P waves in AVR. So now let's go back to our EKG and see if we see this, okay? So this is all for sinus rhythm, again, originating from that sinus node. So lead 1 is here, okay, so you can slightly see some P waves there, okay, and lead 2 is here, okay. These are all upright P waves, all similar morphology. Here's V4, V5, and V6 that you see these upright P waves, okay? And we can also see them in AVF, okay, right there. And then in AVR, we said we would see those inverted P waves. So here's AVR, and that's why you see these negative inverted P waves. So another thing for sinus rhythm to exist is that the P waves have to have that same morphology as we saw, and you want a P wave preceding each QRS complex, okay? And you want to have one P wave for every QRS complex. So again, if we look down here, we can use this V5. So here's a P wave, okay? And then here's our QRS complex, P wave, QRS complex, P wave, QRS complex, okay? And if you went throughout this whole thing, you would see that there's a P wave always preceding a QRS complex, except in this area here, and we'll talk about that complex shortly, okay? So what we can say here is we do in fact have sinus rhythm. So the rhythm origin is from the sinus node, okay? So sinus rhythm, except in this area, that we'll leave that for a discussion later. Now let's look at the ventricular or QRS axis. Now you should have gotten a physiologic left axis deviation that is still within normal limits. The actual value here was negative 17 degrees, which means it's still within our normal limits for adults, okay? So it was actually, physiologic, okay? Leftward axis, and it was negative 17 degrees, okay? Still within that normal limit for adults. So we'll erase this here and look at how do we find the ventricular or QRS axis, okay? All right. So one of the main leads we want to look at, and there's multiple ways you can find access, but the best way, and sometimes the easiest, is looking at leads 1 and AVF, and then if you have to, look at lead 2. So we'll do that here, okay? So remember, this is 0 degrees, where positive end of lead 1 sits. This is positive 90 degrees, where the positive end of AVF is. This was plus or minus 180 degrees, and this is negative 90 degrees. Now remember, normal axis lies between negative 30 degrees and positive 105 or 110 degrees, okay? Meaning that all this here is considered normal axis. Once you start getting in this region here, this would be more of a left axis deviation, and this is what we call right axis deviation, and this quadrant is extreme axis deviation, okay, or sometimes referred to as no man's land. Still a rare thing. Sometimes you can see it in ventricular tachycardia or VTach, okay. So in this case, we have to find the axis. So we're going to look at leads 1, okay, and AVF first. So here's lead 1. Notice that we have these QRS complexes that are upright and they're positive. That means we're going to be heading towards the positive end of lead 1, okay, and then we're going to look at AVF. And notice that in AVF, these are negative complexes, meaning that we're going away from this positive end towards negative 90. That means our axis lies somewhere in this region. And notice that we can either be in this leftward axis, this abnormal left axis deviation, or we can be in this region here, which we sometimes refer to as a physiologic left axis deviation, okay? Still within normal limits, but in that quadrant of left axis deviation, okay? Now in children, you often don't see this because they have that right ventricular predominance, okay? But as we get older, this patient here is 91 degrees. We don't know her medical history. She may have hypertension, and she may be shifting. As we get older, we tend to go more leftward in the axis, okay? All right, so let's see here. What is the axis? Is it normal or is it in this region? Well, what we have to do is now look at another lead, and that's lead 2. Now lead 2 comes down here. This is lead 2, and it sits at 60 degrees, okay? And what's important about lead 2 is that because it's at 60 degrees, if we take the perpendicular to it, it actually goes right along this, which is that negative 30 degrees. Meaning if lead 2 is positive, okay, it'll be heading in this direction towards that lead and put us in that normal axis range. Or if it's negative, it will head this way and put us in that pathologic leftward axis range, okay? So we look at lead 2. So here's lead 2, and notice that it's upright and positive, okay? So upright and positive, meaning that it's going to put us within this region here, okay? And that should make sense. Remember what we said, the EKG machine actually measured it at negative 17 degrees, which means that it's somewhere here, about here. This is negative 17 degrees, okay? So we have at normal axis here, still that physiologic leftward shift, but still within normal limits for adults. Hopefully that makes sense, okay? Now let's move on to atrial conduction. Well, typically we'll look at leads 2 and V1 for P wave or atrial abnormalities, as they appear to be most evident in those leads. The P waves in these leads that we see here are normal in amplitude and duration. Okay, normal P wave duration is typically defined as less than 120 milliseconds, or 3 small boxes. Now, if the P wave duration is prolonged, we are thinking more left atrial abnormalities. This is because the terminal portion of the P wave represents left atrial depolarization, while that initial portion of the P wave represents right atrial depolarization. Anyways, it's normal here, so we won't get into too much detail with that. Okay, so we have normal atrial conduction. All right, now how about atrioventricular or AV conduction? Well, in this case, we're looking for any conduction delays as the impulse travels between the atria and the ventricles. Because the majority of the PR interval generally represents the AV nodal conduction, we look there. Okay, so the normal PR interval in adults, which we're dealing with here, okay, is between 120 and 200 milliseconds, or 3 to 5 small boxes. Here, the PR interval is within normal limits and was found to be measured at 160 milliseconds. Okay, so if you just look here, okay, here's lead 2, and you can see clearly that it is again within normal limits. Okay, it's less than 200 milliseconds, so we have a normal PR interval. Okay, and it was actually on average 160 milliseconds, so less than 200 milliseconds. So that's what we consider normal AV conduction. Let's move on to intraventricular or IV conduction. Here we're looking at the duration of the QRS complexes. Normal QRS duration is often between 70 and 110 milliseconds, or about 2 to 3 small boxes. Some may consider the upper limit to be 120 milliseconds. Anyways, the main thing here we're looking for with intraventricular conduction is whether or not the QRS interval is prolonged. Here we can see that we have narrow QRS complexes that appear within normal limits. In fact, the QRS duration here is 74 milliseconds on average. So that helps to confirm that we do have normal intraventricular conduction. Okay, and that does not include this beat here. Okay, so on average they are normal, meaning that all these complexes here, the duration of them are within normal limits. Okay, so it was normal and on average 74 milliseconds, so clearly less than 120 milliseconds. All right, so how about the waveforms? Okay, so we said that the P waves were normal with no significant P wave prolongation or increase in amplitude in leads 2 or V1. No abnormal Q waves or QS complexes are present here. The T waves are present, they're asymmetric, and they appear normal. Generally, the T wave amplitude decreases with age and tends to be lower in females than males, and it is typically considered abnormal if it's less than 10% of the R wave amplitude. Now, the T wave amplitude is typically greatest in leads V2 through V3, okay, and on average is 0.3 to 0.4 millivolts in adult women. All right, now the PR segment, okay, it's not significantly depressed or elevated anywhere. The PR and QRS intervals we said were within normal limits, and the QRS amplitude appears normal here. Okay, so no evidence of ventricular hypertrophy on the EKG. Now the ST segment does not appear to be significantly elevated or depressed anywhere. And lastly, with the waveforms, we have the QT interval, which here is within normal limits. The QTC interval was measured to be 405 milliseconds. Remember, normal QTC interval in males is less than 440 milliseconds, and in females, which we're dealing with here, is less than 460 milliseconds. So we have a normal QTC interval, so there are no major waveform abnormalities. Okay, so we will just write no other ones. Okay, so no other waveform abnormalities in this case. So is there anything else that we're missing here? Well, how about the R wave progression in the precordial leads? Normally, R wave amplitude should progressively increase from leads V1 through V5, which is for the most part seen here. Okay, so notice that our R waves here are slowly increasing in amplitude. All right, maybe not so much from V3 to V4, but overall, we would probably consider this a normal R wave progression. Okay. Now, how about the transitional zone in the precordial leads? Well, this happens to be occurring in this case between V4 and V5. And what do we mean by the transitional zone? Well, the transitional zone is simply the precordial lead area where the QRS transitions from being mostly negative to mostly positive, with the actual transition area to be where the QRS is isoelectric. Normally, the transition occurs between leads V3 and V4. If it occurs earlier than V3, we call this a counterclockwise rotation or early transition. If it occurs after lead V4, then we call that a clockwise rotation or late transition. Therefore, because the transition appears to occur somewhere between leads V4 and V5, we would actually call this a clockwise or late transition. Okay, so we'll write that here. So again, remember we said that we had a normal R wave progression. Okay, and then in terms of the transitional zone, we said we had a clockwise rotation or late transition, okay, because it occurs between V4 and V5. So just so you're aware of what we mean by this transition, what we mean is that in the precordial leads, which are these leads here, V1 through V6, the chest leads, okay, we want to see the lead where it goes from mostly negative to mostly positive, okay, and the most isoelectric lead, if we see an isoelectric lead, that's where the transition occurs. So V1, notice that the QRS complex is mostly negative, okay, same thing in V2, mostly negative complexes. V3, again, the negative portion is still greater, so these are negative. When we get to V4, if you were to measure these out, again, this would still be mostly negative. All right, but then when we get to V5, you start to see more predominantly positive complexes, okay? And because we're going from negative to positive from V4 to V5, our transitional zone occurs somewhere between there, okay? So that's a clockwise or late transition. Now, one thing to keep in mind with R wave progression and transitional zone is that this is highly dependent on lead placement. All right, now there's one thing we have yet to mention. We keep bringing it up, but that's that complex that appears to be coming sooner than expected and has that compensatory pause. This is a premature ventricular complex, or PVC. Notice that it's not preceded by a P wave and is a wide complex. It is a wide complex because it's originating from within the ventricles and outside the normal conduction pathway. You can think of the normal conduction pathway as being the highway system and the fastest pathway to depolarize the ventricles, which typically gives you a narrow QRS complex, as we see in most of these complexes, okay? However, if you're originating from within the ventricles, as we see in these complexes here, okay, now you are outside and you're taking those back roads to the ventricles to depolarize them and originating from within them, okay, so it's going to be much longer to depolarize all of the ventricles, all right, and therefore you have these wide ventricular complexes that result, okay? So we're outside of our normal conduction system, originating from somewhere within our ventricles. So if we draw our system, remember these are our ventricles. Normally we start up here and come down, but if we're coming from some point within our ventricles, okay, somewhere you have this ectopic focus, one of these that then fires, but it's outside that conduction system, and you have the slow cell-to-cell depolarization, and that's why you have these wide complexes that result, okay? All right, so just to erase, you can see that these are all wide complexes, and notice that the beat is coming earlier than expected, okay? Normally we would expect the QRS to maybe come here, but it's occurring there, okay? And this is that big T wave that you see there. So you have a QRS complex coming sooner than expected, no P wave seen there, okay? So no P wave, and again, then you have the beat that comes after, and again, this would be compensatory pause because this would be two R to R intervals, okay? So from this to this is an R to R interval, okay? But this is two R to R intervals, meaning that we have a compensatory pause, and it's something we typically see with PVCs, or premature ventricular complexes, okay? Now, just a few points on PVCs, and you can find much more information on this in our EKG course if you're still interested. So again, PVCs are early beats originating from an ectopic focus within the ventricles. The general rule is that the fastest pacemaker controls the heart, okay? And in this case, it's coming from the ventricles. Now, in terms of mechanism, there's usually an unusual irritability of an automatic pacemaker cell within the ventricles that then sets off. Now, some causes that you can see it from are anxiety, myocardial ischemia, hypokalemia, meaning low serum potassium levels, hypomagnesemia, okay, so low magnesium levels in the blood, drugs such as excess caffeine, okay, beta agonists, as well as digoxin toxicity, all right, among many other causes, okay. Now, in terms of clinical significance of this, they're often benign unless you have a prolonged QT, and that can lead to torsades, all right. You typically don't need treatment with these, and you may have palpitations associated with them, and that may trigger a reentrant tachyarrhythmia. Now notice that our patient here had palpitations, and that does make sense that we are seeing this PVC here. Maybe if we had more of an EKG or had a Holter monitor, we might see a few more when she's experiencing those symptoms. Okay, we mentioned there's that compensatory pause, so the overall timing of the beats is not affected. There's discordant ST and T wave changes. And what do we mean by discordance? Well, notice that in our normal complexes, we have these upright QRS complexes, mostly positive up, and the T wave is also upright. However, when we look at our PVC, or the premature ventricular contraction, notice that our QRS complex is mostly negative, but then our T wave is mostly positive. So we call that discordant, and that's something you tend to see with premature ventricular complexes. Remember, normally we have concordance between the ST and T waves. Okay, so this is discordant ST T wave changes, and hopefully that makes sense there. Another few points with these is that they result in an irregular rhythm, as we saw here. It made it regularly irregular. Okay, the rate again depends on the underlying rhythm, which we found to be about 80 beats per minute here. Okay, there tends to be no P waves, as we see here. Okay, and so notice these are all the same PVCs occurring at the same time because of that temporal relationship of the EKG. There may be retrograde P waves because secondary to retrograde conduction, meaning that the PVC that started from the ventricle, so maybe it started here, depolarized throughout here, and maybe it got conducted backwards and you saw some atrial depolarization. Okay, so we call that a retrograde conduction. So you can see sometimes a retrograde P wave. Okay, now in terms of the P wave to QRS ratio, there's often none unless you have that retrograde P wave conduction present. Okay, there's no PR interval because there's no P wave. The QRS interval we said is prolonged, so greater than 110 milliseconds, or at least sometimes some will consider that 120 milliseconds, as we see here, and that abnormal QRS morphology. Okay, notice that the QRS complexes have a different morphology. Okay, these complexes here have a different morphologies than those that surround it. Okay, so that's one thing to know. There tends to be no grouping or drop to beats present. Now in terms of terminology of these PVCs, when we call them unifocal, that means that they have one focus, so coming from one area in the ventricles, and they have one morphology. Whereas if we call them multifocal, that means there's more than one foci and there has multiple morphologies associated with them. If you have a bigeminy PVCs, that means that every second beat is a PVC. If we have something called trigeminy, that means every third beat is, and quadrigeminis, every fourth beat would be a PVC. Okay. You may hear of couplet PVCs, and that just means 2 consecutive premature ventricular complexes, or triplet means 3 consecutive PVCs. Okay. So hopefully that makes sense. Now there's one last thing that we can touch on. It's a little more advanced, and that has to do with where is the origin of the PVC coming from. Okay, and the origin, if it's coming from the right ventricle, remember these are ventricular contractions. Okay, so they're coming from the ventricles down here, and are they coming from the right ventricle or the left ventricle? Okay, well you can tell by often looking at lead V1. All right, so in lead V1, you're looking at the complex, okay, and if it has a dominant S wave, then we would say that it is likely coming from the right ventricle. If it has a dominant R wave, then we would say that it is coming from the left ventricle. Okay, so let's look at this. Here's lead V1, and notice our PVC here has a mostly negative complex. Okay, so it's mostly negative QRS complex. That means that it is coming from the right ventricle, dominant S wave. Okay, and why is that? Well, imagine lead V1 sitting over that right ventricle. It's one of our right precordial leads. Okay, and if you have the ectopic focus originating from within the right ventricle, it's going to head away from it. Okay, so if you imagine V1 somewhere in this region and you have the complex originating from here, it's going to head away from it, so you'll see a negative complex. Okay, whereas if you have the left ventricle, which sits more posteriorly, and you have an ectopic focus, it's going to depolarize more anteriorly, and you'll see an upright dominant R wave. Okay, so a little more advanced, but some of you may like that stuff. So Yeah, hopefully that was helpful. Okay, so that's premature ventricular contractions, and let's look at our final interpretation here. So we said we have a regular rhythm with sinus origin in the rate is 79 beats per minute. The ventricular axis we said is physiologically normal, okay, although has that leftward shift. There is normal atrial, AV, and IV conduction. There are no abnormal waveforms, and the R wave progression in transitional zone, okay, that we saw here, that normal R wave progression, the clockwise or late transition in the precordial leads, okay? And then we saw that we had the premature ventricular contraction, or PVC, present there. So this is an EKG that shows sinus rhythm and a PVC, but is otherwise normal. So great job if you're able to get that on your own. Now, when compared to the previous EKG, the differences here included a PVC present and a decrease in the PR interval. And you always want to look back at a previous EKG to make sure that there are no significant differences that you may be missing from the most current one. All right, so let's write our final interpretation and finish up here. Okay, so we'll make some room. So our final interpretation is that we said we have sinus rhythm. Okay, we noticed that we had that PVC present that we pointed out, and then we said that it is an otherwise normal ECG, okay? And then when compared to the previous one, what did we say? We said now we have the PVC present that wasn't there on the previous one, so we want to note that. And we said that there was a decrease in the PR interval. Okay, so in conclusion, our 91-year-old female that presents with this intermittent palpitations has an EKG showing sinus rhythm in premature ventricular complexes. Well, that's the end of this EKG of the week, okay, and I hope you learned something. Have a wonderful week. Welcome to the EKG Guy, and welcome to the EKG of the week. I hope you're having a wonderful week, and I'm glad you could join us. So this week's case is an 85-year-old male with a history of hypertension and COPD that presents with shortness of breath. His presenting EKG is shown here. Before we get started, let's review the approach we've been using to interpret the EKG. So notice we have the patient's clinical presentation and then the EKG below it. On the right side of the screen, you'll see that we have a list that we'll go through before making a final interpretation. First, there's the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? If it's irregular, is it regularly irregular or irregularly irregular? Next, we have the heart rate, in which we simply want to determine the rate of the rhythm. Then we have to look at the rhythm origin. That is, where in the heart is the rhythm actually originating from? Then we'll look at the ventricular or QRS axis, which could help us with our differential diagnosis. And then there is the atrioventricular, and intraventricular conduction, looking at if conduction is normal or abnormal in any area of the heart. Then we have the waveforms, which would be all the waves, the segments and intervals, and lastly, anything else, meaning is there anything else that we've missed or still need to mention, where we'll look at the R wave progression and transitional zone in the precordial leads. After that, we'll use all the information that we've gathered to make a final interpretation of the EKG in front of us. And as always, we will compare it to a previous ECG to make sure that the one that we're looking at here doesn't have any new changes from a previous one. Now I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll go over it together. Alright, so our 85-year-old male with a history of hypertension and COPD presents with shortness of breath in the following ECG. Let's go through it. So first, what is the regularity of the rhythm? Well, on first impression of the EKG, you probably noticed that the rhythm appears irregular, and that is correct. In fact, this is an irregularly irregular rhythm. Okay, so this is an irregular rhythm. That's how we'll denote it here. So what we do, and oftentimes you can use any interval you want, we'll often use the R to R interval, which is from one R wave, okay, to the next. Remember the R wave, the first positive deflection of our QRS complex, often after a P wave. So this is the R to R interval, okay? And then we look at the next R to R interval. You can already see that these are different, and because they're different, all right, and there's no pattern to how they're different, we call it an irregular, okay? And there's no regularity to the pattern whatsoever, right? All these are completely different, so we call it irregularly irregular. All right, so how about the heart rate? Well, because we have an irregular rhythm, we can estimate the rate of this, okay? We can look at the ventricular rate, we'll do here, by adding up the complexes going across the EKG, multiplying it by 6, okay? Because we know the standard 12-lead ECG, which we're looking at in front of us, represents 10 seconds in duration, okay? So just so you're aware, from beginning all the way to the end is 10 seconds. 10 seconds times 6 is 60 seconds, which is 1 minute. So if we count these ventricular complexes, so these here, going across, we'll get, and then multiply it by 6, we'll get an estimate of that rate in beats per minute. So let's do that here. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, okay, and 20. So we have 20 complexes. We multiply that by 6, and we get a rate of about 120 beats per minute. Now the machine gave us a rate of 122 beats per minute, which is close enough, and we'll take that. So hopefully that makes sense, all right? So let's just clear this up. So 122 beats per minute is our ventricular rate. You can also find the atrial rate by doing the same thing and just counting up the P waves, all right? You can use the T waves and also use that to find the ventricular rate as well. Now let's look at the underlying rhythm origin. So we have narrow QRS complexes, so we know that this is a supraventricular rhythm, or one originating from above the ventricles. We can also make out clear defined P waves in each lead, although these P waves morphology are not exactly the same in each. In fact, there seems like there's at least 3 different P wave morphologies, okay? And therefore, we're likely dealing with an atrial rhythm not originating from the sinus node. So if you look here at lead 2, notice that these P waves, these first 3, are completely different, okay? Even different from these that follow it. And that may indicate that we are in fact not dealing with a sinus rhythm, okay? So we have an atrial rhythm because there's P waves present. We don't have a sinus rhythm because in sinus rhythm we want the P waves to have similar morphology, and so that should make sense there, okay? But we have 3 different, or at least 3 different P wave morphologies, probably more than that here. So 3 different areas in the atria are starting the impulse in conduction through down to the ventricles. Let's look at the ventricular or QRS axis, okay? And you should have gotten a normal axis, so this is actually normal. We'll go through why that's the case, and it was actually came out to -2 degrees, okay? So what you need to know here is that 0 degrees sits here. This is where positive 90 sits, okay? This would be positive 180 degrees or minus 180 degrees if you went the other way. So that's where minus 90 degrees sits. Now we're dealing with an 85-year-old male. We know that the normal axis in adults is -30, okay, to about positive 110. So all this is a normal axis here. This would be a pathological leftward shift, okay? This is extreme axis deviation, or no man's land, or right superior axis. This is right axis deviation here, okay? Now what we want to do, and the leads I want you to keep in mind, are leads 1 here and lead AVF, and that's the positive end of each of those leads. So if you look at lead 1, notice that our QRS complexes are upright, meaning that we're going towards the positive end of lead 1. Okay, next we look at AVF, which is down here, and actually if you were to look at positive and negative, the R to S wave, the R to S ratio is about 1, so it's isoelectric, okay? So if it was positive, we'd be going this way. If it was negative, we'd be going this way, but it's isoelectric, so we're pretty much perpendicular to the AVF lead. Now another lead that can help us confirm we have normal axis is one that comes here, and that's lead 2, and it sits at positive 60 degrees. So lead 2 here is mostly positive compared to the negative deflection, putting us somewhere here. And as we noted, this is -2 degrees, okay, and it makes sense. AVF is the most isoelectric here, so perpendicular to that lead puts us at that ventricular axis. So normal axis at -2 degrees, okay? Now how about atrial conduction? All right, well here we want to often look at leads 2 and V1 because the P waves or atrial abnormalities seem to be most apparent in those leads. The P waves are present in both leads here, although as we mentioned earlier, they have multiple different P wave morphologies. And one thing to keep in mind is that we are assessing, when we assess for atrial enlargement, whether it's left or right, the proposed criteria that's out there assumes that sinus rhythm is present. And because we said that sinus rhythm is not present here, we cannot say anything about atrial abnormalities at this point, okay? So hopefully that makes sense, and because of that, we have to say that this is indeterminate, okay? So we cannot say anything whether we have right or left atrial enlargement, because we do not have sinus rhythm present. We said it's coming from the atria. Now, how about atrioventricular or AV conduction? Well, in this case, we're looking at for any conduction delays as the impulse travels between the atria and ventricles. Because the majority of the PR interval generally represents AV nodal conduction, we look there. The normal PR interval in adults, which we have here, is between 120 and 200 milliseconds, or 3 to 5 small boxes. Okay. Here, the PR interval is within normal limits, but we cannot say use what the machine is giving us because the PR interval has multiple. We have multiple ectopic atrial foci. Therefore, the PR interval will vary. Okay, and we don't have a set defined. So we have different atria that are fired, different foci in the atria. Because of that, we have different PR intervals. Okay, but regardless, we can say this is normal because as the atria fires and gets down to the ventricles, it's normal. We have 1-to-1 atrial to ventricular conduction, and there are no drop beats. So in this case, we will say it's normal, okay, because for every P wave that fires, we get a ventricular complex, okay, and we have no drop beats, all right. But you'll notice that the PR interval changes there. So normal AV conduction in this case, all right. Next, we have intraventricular or IV conduction, and here we're looking at the QRS duration or QRS interval. Okay, the normal QRS duration in adults is between 70 and 110 milliseconds, or 2 to 3 small boxes. The main thing we're checking with intraventricular conduction is whether or not the QRS interval is prolonged. We can see narrow QRS complexes that appear within normal limits, and in fact, the QRS duration here was 98 milliseconds, helping to confirm that IV conduction is normal. Now, note that the QRS duration will be the same for each beat, okay, because everything below the AV node is occurring as it normally would with a sinus beat. The only issue is that we have different origins of the atrial beat. So even though the P waves are firing, you'll notice that our QRS complexes end up looking similarly, okay. So IV conduction is normal, we said here, and the width of it we said was 98 milliseconds, is within that normal limit range. Now, how about the waveform? So P waves, we said we had multiple varying morphologies, therefore we noted sinus rhythm was not present and could not say anything about atrial enlargement. There are abnormal Q waves present in V1 to V3, and then when we look at the lateral precordial leads, V5 and V6, we see these large R waves. So the combination of these in the setting of discordant ST segment and T waves suggests left ventricular hypertrophy. More specifically, the S wave in V2, or more the Q wave here, and the R wave in V6, okay, are greater than 35 millimeters in amplitude, further suggesting that we have minimal voltage criteria met. Okay, now these deep Q waves and loss of anterior precordial forces suggest that we may have an anteroseptal infarct as well here. So V1 to V3, and notice that we have these deep Q waves. Okay, these are deep Q waves. And then this is an R wave, so this is an S wave that follows it. And then in V5 and V6, we have these big, tall R waves, okay? All right, and we're saying that this is suggesting left ventricular hypertrophy. So remember, the criteria that you should take away here is that an S wave, in this case it's a Q wave, in V1 or V2, whichever is deeper, and we're saying V2 here we're using. So if we take this Q wave here and we count up these big boxes, 2, 3, 4, 5, okay? If we add that, okay, to the R wave, the largest R wave in V5 or V6, okay? In this case, we can use V6 because it's the tallest here. So from top to bottom, okay, if that is greater than or equal to 35 millimeters, it suggests that we have criteria for LVH met, okay, the voltage criteria. So you can clearly see that we have 1, 2, 3, 4 at least, okay, and you need at least 7 big boxes, okay, or 35 millimeters to meet that. So we clearly meet that here, okay. So because of that, we will write that we have the LVH, the voltage criteria met, okay. We also noticed that we said we have discordance, so notice what we mean is that the main QRS vector is up, and then we have ST segment depression and T wave inversion here, okay, which is going in the opposite direction. That's discordance, okay, and we call those secondary repolarization abnormalities, okay. And you see the same thing here. Notice that we have these deep Q waves and then upright ST segment and T waves. All right, so those are discordant things. And we also mentioned the deep Q waves in V1 to V3 to be aware of, because that may suggest that we have either an ongoing infarct or one that was prior previously present. Now there are some non-specific ST T-wave changes that are present here, okay, and you can see those in lead 1, so not really much, just flat T-waves there. Okay, nothing to be too concerned of. The PR segment is not significantly depressed or elevated. The PR interval we said was varying in the setting of the multiple ectopic atrial foci. The QRS interval was within normal limits. The ST segment is depressed in leads 2 and 3, but less concerning because these are not contiguous leads. Okay, so lead 3, here's lead 3. You can see there's some depression there in the ST segment slightly, and same thing here in 2. Okay, but you don't really see that in AVF, and because they're not contiguous, you don't get too excited about that. Okay, there's also some ST segment depression. We mentioned those lateral precordial leads. So these here we mentioned that were part of those discordant or repolarization abnormalities. Same thing with the ST elevation here that we saw in some of these leads here, and maybe also slightly, not so much in V4, but yeah, so those are those discordant changes, the repolarization abnormalities we mentioned in the setting of LVH. Okay, and lastly with the waveforms, I want you to be aware that the QTC, so QTC, which is the corrected QT interval, corrects for heart rate. Okay, often we'll use the Bazette formula the machine will use and set a standard rate of 60 milliseconds, okay, or 60 beats per minute as the heart rate it uses. Okay, you can also use the Framingham, but the QTC here was actually prolonged at 516 milliseconds. Okay, we have a male patient here. We normally wanted about 440 milliseconds or less. Okay, and females 460 milliseconds. All right, but when we get up around 500, we get a little concerned about giving certain medications. So that's something to be aware of in this patient. Okay, so if the patient was nauseous, giving Zofran may not be the best idea. We don't want to precipitate any arrhythmia, ventricular arrhythmia, with that prolonged QT. Okay, all right. So is there anything else that we're missing here? Well, how about R-wave progression, the precordial leads? Normally the R-wave amplitude should progressively increase from V1 to V5. In this case, it seems like that is not certainly the case. Okay, in fact, the initial R-wave is pretty much absent until lead V4, and this is poor R-wave progression and suggests that we have poor antral septal forces. Okay, so just to take this off so we can kind of clear this up, and what we're looking here in these last two things, the R-wave progression and transitional zone, are in these precordial leads. So these leads here, and notice that in V1 we don't even have any R-wave. Same thing in V2, and the R-wave should normally increase, and then we start to see it here, okay, in V4, okay, and then you see a big increase in V5. Normally it should slowly increase from V1 to V5, and because we don't see that, we call this poor R-wave progression, and that means that we likely have poor antral septal forces. Remember, the septal forces here in V1 to V2, and then the antral leads all over V3 and V4, often including V2 as well. Okay, you can see that we have these poor antral septal forces. Okay, that's what that poor R-wave progression likely suggests. All right. Lastly, we have the transitional zone. In this case, it seems that to occur between V4 and V5. So here's V4 and here's V5. Okay. Now the transitional zone is simply the precordial lead where we go from QRS transitioning from being mostly negative to positive in those precordial leads, with the actual transition area where the QRS is most isoelectric. Normally the transition occurs between leads V3 and V4. If it occurs before V3, we call it a counterclockwise rotation or early transition. If it occurs after V4, we call this a clockwise rotation or late transition. Therefore, because the transition occurs to be somewhere between V4 and V5, we would call this a late transition or a clockwise rotation. Okay, so clockwise rotation or late transition. All right. Now, one thing to note and keep in mind with R-wave progression and transitional zone, these last two things, is that they're highly dependent on lead placement, which is certainly an imperfect science and technician dependent. So be careful how much you put into those things. Okay, make sure the leads are placed properly. Anyways, what's our final interpretation? Well, we have an irregularly irregular rhythm, we mentioned. Okay, we have a rate of 122 beats per minute, and we noted at least 3 different P-wave morphologies suggesting an atrial rhythm. Okay, and that's originating from outside the sinus node alone. And these findings together give us a rhythm called multifocal atrial tachycardia, or MAT. Okay, and multifocal atrial tachycardia means when you have at least 3 different P wave morphologies, the rate is over 100 beats per minute, as we see here, and it's an irregularly irregular rhythm. Okay. Now, if the rate was less than 100, we would call that wandering atrial pacemaker. Okay. So the only thing differentiating the two is the rate here, so above 100 beats per minute. So we have multifocal atrial tachycardia. We said we have a normal ventricular axis. AV nodal and intraventricular conduction were normal in this context. However, we noted evidence of LVH, or left ventricular hypertrophy, with secondary repolarization abnormalities, nonspecific ST T-wave abnormalities, and a prolonged QTC interval. In addition, we saw deep Q waves and poor anteroseptal forces and a late transition. Okay, or that clockwise rotation. All, when taken together, suggest we cannot rule out an anteroseptal infarct, and we need to add the clinical context and review a previous ECG if available. When reviewing the patient's previous ECG, what we see is actually those deep Q waves are there. Okay, and the only new change that we see here is sinus rhythm is no longer present, and it's replaced with multifocal atrial tachycardia. Okay, so just to review, we have multifocal atrial tachycardia. We said we have left ventricular hypertrophy with secondary repolarization abnormalities. Okay, we also mentioned that we have a prolonged QTC. That's important to be aware of. Okay, we also mentioned that we have nonspecific ST T-wave abnormalities. Okay, and the other thing here, we said that we cannot rule out an anteroseptal infarct, okay, because of the clockwise rotation, those poor R wave progression, those deep Q waves. All right, and then when we looked at the previous ECG, those were actually there, which is reassuring, okay, and the only thing we saw is that sinus rhythm is no longer present. So sinus rhythm no longer present, replaced with this multifocal atrial tachycardia. Okay, so that's the rhythm that's replaced it. Now, one last thing to point out is that the patient has this new onset multifocal atrial tachycardia, and this can be seen in COPD, as our patient has here, okay, and congestive heart failure. It is often seen in these ill elderly patients with respiratory failure, which may have been the case in our patient here, okay, presenting with shortness of breath and COPD. Now, multifocal atrial tachycardia tends to resolve after we treat the underlying condition, but it can be a sign of poor prognosis if it develops in the acute setting. All right, so let's wrap up our case here. So our 85-year-old male with a history of hypertension and COPD presenting with shortness of breath has this EKG showing multifocal atrial tachycardia, evidence of left ventricular hypertrophy with secondary repolarization abnormalities, a prolonged QTC interval, nonspecific ST T-wave changes, and that we cannot rule out the anteroseptal infarct, but when we look back at the previous ECG, they're there, and all we have is sinus rhythm no longer present, replaced by multifocal atrial tachycardia. Well, that's the end of this week's EKG of the week. I hope you learned something. Hello, welcome to the EKG Guide. Welcome if this is your first time. I hope you're having a wonderful week, and thanks for joining us. So this week's EKG of the week, we have a 67-year-old male farmer presenting with substernal chest pain worsened with exertion. Okay, here's his presenting EKG. Okay, and then I want you to take a look and try to interpret it yourself. Okay, try to figure out the regularity, rate, rhythm origin, where's the rhythm actually originating from, ventricular axis, atrial conduction, atrial ventricular AV conduction, IV or intraventricular conduction waveform. So try to fill out those on the right. Okay, you can pause the video when you're ready, restart the video, and we'll go through this together. All right. So hopefully you had a chance to go through it yourself. Okay, and so we have a 67-year-old male farmer presenting with substernal chest pain worsened with exertion. Okay, so first we want to know, what is the regularity of this rhythm? Okay, so this is how I want you to approach each EKG, and you'll have other people that have their own, style, but this is something that helps me not to miss anything. And so far it's worked pretty well. So the regularity of the rhythm, that's up here. Okay, so we want to look at the intervals here. And one of the easiest things is to take these R to R intervals. So here's one R wave, here's another, here's an R wave, here's an R wave. Okay, R waves are positive deflections of our QRS complexes. Okay, so an R to R intervals from one R wave to the next, that's an R to R interval. Here's the next one that follows, and so forth. Okay, and then you have another R wave, another R to R interval, and you can see that they vary in duration throughout, okay? So this is an irregular rhythm, but because it's irregular, there's also, you may notice that some of these are kind of grouped together. There's 2 here, 2 here, 3 here, 2 here, okay? So not so much regularity to it, so we would still call this an irregular rhythm in terms of the R waves or QRS complexes, okay? But there are some other waves that are occurring more regularly, and those are the P waves, okay? And the P waves are these here. Here's a P wave, here's another one, okay? A P wave here, here, here. And if you were to measure these out, these would be all P waves, okay? So from one P wave to the next. This is what we call our P to P interval, okay? And that throughout all of these P waves are the same. So you're kind of dealing with an atrial rhythm that is regular, and then a ventricular rhythm that has some irregularity to it. So for the atrial, we'll call it A, and then ventricular V, okay? The atrial will be regular, and then the ventricular, in this case, we'll call it irregular, okay? So when finding the rate here, the next thing is a rate. We have probably 2 different rates we can find. The machine often gives you the ventricular rate, but it's good to know how to find that. And because we have 2 different rhythms that we're dealing with here, okay, or not so much rhythms, but 2 different rates, we have an atrial rate and a ventricular rate. We have to know, so let's just erase this here so we can start fresh. We have to know that this 12-lead ECG that we have in front of us from beginning to end, so from the beginning all the way to the end, represents 10 seconds. And 10 seconds times 6 is 60 seconds, and you should know that's 1 minute. And what that means is if you count the number of complexes, whether P waves to find the atrial rate, or QRS complexes, or T waves to find the ventricular rate, and multiply that by 6, you can get the rate and estimate in beats per minute. Okay, so same thing here. And because we're not dealing with both fully regular rhythms, we'll use this way, okay, to find the rate. There's other ways you can use when you're using a regular rhythm, but we won't go through that in this lecture. So in this case, let's find the atrial rate first. So we said here's 1 P wave, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay, so you would want to do 14 times 6. So let's do our math here. 14 times 6 is 24, and 84 is our rate. So an atrial rate of about 84 beats per minute. So we'll put atrial rate of 84 beats per minute. Okay, then we have a ventricular rate, and we'll count out these QRS complexes. So here's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so 10 and 10 times 6 is 60 beats per minute. So an average rate of 60 beats per minute. Remember, the machine will give you the rate, and what they calculated was 62 beats per minute for the ventricular rate. So quite close. Okay, a good estimate. All right, so hopefully that makes sense. So far we have 2 different rates that we found. We found the atrial. Remember, atrial rate, you want to use the P waves. Okay, ventricular rate, you want to use those QRS complexes. You could also use T waves because they represent ventricular depolarization. Okay, so next we want to look at the rhythm origin. Okay, where is the rhythm actually originating from? Well, we know that there are P waves present. Okay, and are the P waves associated with the QRS complexes? Well, it seems like this P wave comes here. There's one that follows, and there's a P wave. But then there's a P wave, and then no beat. There's a P wave and the QRS. P wave and a QRS. P wave, no beat. Okay, no QRS beat. P wave, QRS, P wave, QRS, P wave, QRS, P wave, and then a drop beat. Okay, so you can kind of see that throughout. So not every P wave is associated with a QRS complex, and that should make you think that we may be dealing with some sort of block here. Okay, so we will get to that in a minute. Now, one thing to note is that the rhythm is actually originating from the sinus node. Okay, and how do we know that? We know that it's a sinus rhythm because, remember, in sinus rhythm, if we have our box diagram here, here's our right atrium, right ventricle, and left ventricle. The sinus node is up here, okay, and conduction heads this way towards the AV node and then to the conduction system in the ventricles. So if we overlay the right atrium, which is this portion here, onto this, imagine that's our right atrium. Here's our sinus node. Conduction's heading in this direction. Here's our lead 1, okay? AVF, lead 2, AVR, okay? So, and then we have our horizontal plane, V4, V5, and V6. If the wave, which we have here, is heading in that direction, we should see upright P waves in those leads in sinus rhythm, if it's coming from the sinus node, and invert in AVR. So if we look here, we said that lead 1 has upright P waves that we see. Lead 2, the same thing. Lead AVF does as well. Okay, here's V4, you can see somewhat V5 and V6, and then AVR has these negative P waves. So in fact, we do have a rhythm that's originating from the sinus node. Okay, sinus rhythm, and the atrial rate's at 84 beats per minute. All right, but there's also some conduction delay that we'll get to in a moment. All right, so let's move on to the ventricular axis. Now, ventricular axis in adults normally is between -30 and positive 110 degrees. Okay, so let's just erase this here, clear it up. All right, so here we go. Now we have normal axis is between -30 and positive 110 degrees. Okay, now let's just orient ourselves here. Okay, if this is normal, this is left axis deviation, this is right axis deviation, and this is a northwest axis, or no man's land, okay, or superior rightward axis. Here's north and west, okay, that's why it's northwest axis. So what we have to know here is that lead 1 sits here, AVF is down here. Okay, there's many ways that you can use to find the ventricular axis, and we're going to use this way because it's easy to learn. Okay, so here's lead 1, here's AVF, okay, normal axis is here. Let's look at what lead 1 and AVF show. So lead 1, lead AVF. Notice our QRS complexes are mostly positive, okay? Mostly positive QRS complexes, which means we go towards the positive end of lead 1. Okay, this is the positive end of lead 1, positive end lead of AVF. Here is AVF, okay, and you'll notice that AVF is mostly negative, okay? Notice that this is mostly negative down here. So mostly negative, meaning we'll go away from AVF and go this way. Okay, that means our axis lies somewhere here, but now we need to determine which side of this line is, because we said this was normal over here, but this was left axis deviation. Okay, how do you do that? Well, you need to use another lead, and that lead is lead 2 that sits at positive 60 degrees. And why do we use lead 2? It's because here's lead 2, perpendicular to that is actually this lead here that goes to -30 degrees, which means that if lead 2 is positive, it'll be in this region here, okay? If lead 2 is negative, our axis will be over here, okay? So if we look at lead 2 and you measure, here's baseline, here's the positive and negative, okay? It's actually almost isoelectric, okay? And it's isoelectric, meaning that it's pretty much on this line, on this -30 degrees. All right, so because of that, we have somewhat of a normal axis or borderline left axis deviation. Okay, so we can say borderline left axis deviation. All right, and because of that, the actual axis that the machine got was -29 degrees. Okay, and -29 degrees would come pretty much right here, so slightly within that normal range. So we'll say normal for now. Okay, so normal in our adult male patient. Remember, this is adults. Children have a different axis ventricular because the right ventricle is the most dominant. Okay, especially at the end of the gestational period and early into the infancy period. Okay, before the left ventricle starts dominating. All right, so next we have atrial conduction, and this is where we look at the P waves. Are there any atrial abnormalities? Okay, well, we looked at where the rhythms are originating, okay, but now I want to know, is there any left atrial or right atrial enlargement? Okay, and the best leads to look at are leads 2 and V1. Okay, I'll erase this here as to not confuse you. So leads 2 and V1, and atrial abnormalities, that means we are looking at the P waves. Okay, so with our P waves, okay, we're looking at these rhythms, and remember that the beginning of the P wave represents right atrial depolarization, and the terminal portion represents left atrial depolarization, okay? And what we do notice here, we won't get into all the details, but there is evidence of left atrial depolarization, okay? So in V1, you can see these biphasic P waves. The beginning of it represents the right atrial depolarizing, and this is the left atrium depolarizing. When we look for left atrial enlargement, we look at this portion. When we're looking at for right atrial enlargement, we look at the beginning, okay? And for left atrial enlargement, you want at least 1 millimeter wide and 1 millimeter deep, okay? And in that, it's hard to see here. I'll kind of erase that, but it is actually present there, okay? So we do make it there, but another lead to look at is lead 2, or any of the inferior leads, okay? Lead 2 is a good one to look at. And what you want to look for left atrial enlargement is something like this. From the peaks, from this peak to this peak, you should have at least 40 milliseconds in width, which is one small box, okay? And then from beginning to end of the P wave, it should be at least 120 milliseconds, which is 3 small boxes, okay? And if you were to see these or measure them out, you'd actually see some of that notching there, okay? Maybe you could see it better down in these leads. Hard to make out if you're not zooming in, but if you trust me, it is there. So we do have evidence of left atrial enlargement, okay? And in lead 2, the reason why you have it prolonged is because, remember, the terminal portion is the left atrium, and it'll push it this way. For right atrial enlargement, you're going to see peaking of these P waves in the inferior leads. All right, so now we have AV conduction, okay? So there's a lot here in this EKG that you can already start to see. So AV conduction, we said that we have P waves, but there's some of them that are not followed by a QRS complex, meaning that we have dropped beats, okay? And what we have here is a P wave, a dropped beat, a P wave, QRS, P wave, QRS combo, okay? P wave, dropped beat, there's a P wave and QRS, P wave and QRS, P wave, drop beat, P wave QRS, P wave QRS, P wave QRS, P wave, drop beat, okay, and so forth. All right, and it seems like there's another drop beat here at the end. So what does this indicate? All right, so there's some sort of block going on. All right, and what you have to notice here, just erase some of these, is that these P wave, the PR interval, which if you look here, here's our QRS complex, the PR interval, which is from the beginning of our P wave to there, is actually constant when it's followed by a QRS complex, okay? So these PR intervals that you see here are constant when they're followed after a QRS complex. And why that's important is because if they weren't constant and you saw dropped beats, it could indicate a third degree AV block or a Winky block, okay? But because you have these constant PR intervals and then intermittently you have drop beats, this is what we call a second degree AV block, Mobitz type 2, okay? So second degree AV block, and this is Mobitz 2. Okay, Mobitz 1 is Winky block, where you have the longer drop, that meaning the PR interval gets lengthened and then you have a drop beat. Okay, but notice that this is not third degree AV block. You have P waves associated with QRS complexes. Okay, there's certainly association there. All right. So let's move on to IV conduction. IV conduction, I'm pretty much looking at these QRS complexes. IV meaning intraventricular. What is the conduction within the ventricle? So here you want to look at the duration of the QRS complex, okay? And what normal duration is between 70 and 110 milliseconds, okay? Or less than 3 small boxes. Once you start hitting 120 milliseconds or more, we start considering this abnormal. Okay, and I was reading another book today that even put it up to 100 milliseconds. So anyways, less than 120 milliseconds is what most references will consider normal. And we're going to stick to that. So here, the machine gave us, instead of it's hard to make it out on your own, is that the QRS duration, or QRS interval, was 128 milliseconds. So we would call that intraventricular conduction delay, okay, meaning there's delay within the intraventricular, the conduction within the ventricles, okay, and that can be from a bundle branch block that we may see here or some other things. So let's get moving on because there's still a lot to cover here. So we have some prolongation of the intraventricular conduction. Now let's look at the waveforms, okay? And this is where you're going to look for PR segment elevation or depression, which there is none, okay? Are there any abnormal Q waves, okay? Well, this patient presenting with substernal chest pain and worsened exertional symptoms, you want to look for ischemic symptoms or ischemic patterns on the EKG. And if you look here, these are deep abnormal Q waves in those anteroseptal leads, okay? In addition, you may notice that there is ST elevation, okay? So here's our baseline. You can see some ST elevation also in these leads, maybe even slightly there, okay? And flattening of them, okay? Those are ischemic signs. And because you have Q waves associated with ST elevation, this is most likely an acute infarct. Okay, so that's one thing to keep in mind. It's involving leads V1, V2, V3, and V4, which are the anteroseptal leads. Okay, notice in V5 you start to still see that R wave. Okay, so that's still expected and maybe not involving that region of the heart. So that's what I want you to see here, is that there's an anteroseptal infarct, okay, in those leads. And that's likely an acute, all right, not an old one, because you have associated ST elevation changes. Obviously, you want to look back at a prior EKG, and actually these are new changes. So that's one thing to keep in mind, okay, as well as the clinical context of all this is going on with this typical anginal pain that's worsening with exertion. All right, another pattern I want you to notice here, I told you there's a lot going on here, is a right bundle branch block. Okay, well, you may say, I don't see that rabbit ears pattern. Well, you have to know that even in the setting of an infarct, you can still have a right bundle branch block pattern. It does not obscure it. Where in left bundle branch blocks, we start thinking of using Sgarbossa criteria or some other ways to identify it, because the left ventricle makes up most of the QRS complex. Okay, so what do I mean by a right bundle branch block pattern? Well, what you have going on here is a QR prime pattern, okay? Meaning that this R wave, the initial R wave that you tend to see, okay, with an RS, R prime pattern in a right bundle branch block is not present, okay? Instead, that initial R wave, okay, if you imagine here's your complex, that initial R wave is now pretty much dead and now inverted because of this infarct pattern. So whether it's an old or a new infarct, you can see this, okay? So notice you have a QR wave, okay? This R wave, this late R wave, that late vector that's coming towards the right ventricle, this late vector, okay, here, that slurred S wave that we see here, okay, the prolongation of the QRS complex, this is a complete right bundle branch block pattern. So complete right bundle branch is present here as well. All right. Is there anything else? Well, we've hit on a lot, okay, already here with the ST elevation that we mentioned in the anteroseptal leads. Okay, so the ST elevation, the Q waves that were abnormal in those leads, V1 through V4. All right, so let's look at, there's nothing else here. I just want to make a comment on the QTC interval. Okay, the QTC interval was actually 345 milliseconds. Now, sometimes in infarcts, you can see this prolonged, but here it's normal in this male. Okay. All right, next we need to see, and why may this QTC interval recorded by the machine be a problem? Well, notice we have dropped QRS complexes, okay, and it usually takes into account the Bazet formula, which takes into account the R to R interval, and if you have these changing R to R intervals, it's hard to trust the EKG machine, and that's probably why it's so low. Okay, so again, you have to be aware of this as to not rely heavily on the machine. Okay, R wave progression. Well, in this case, this is in the precordial leads, these last two things. The R wave from V1 all the way up to V5 should increase in amplitude, but notice that this initial R wave is not there. There's not one in V2 or V3 or V4. We start to see it in V5 and V6. So this is what we call a poor R wave progression. poor R wave progression, and that can be seen when you have lack of those anterior forces, like in the setting of an anteroseptal infarct. All right, so another thing that points to that. Where's the transitional zone? Meaning, where are the complexes going from being mostly negative to positive? Okay, well, it's hard to tell here because you have this big force coming to the right ventricle. Okay, but let's use these initial forces. I think that's the best to use here when you're looking at these last two R wave progression and transitional zone. So this is a big negative. Okay, negative, 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 and we say the transition's probably here. Okay, so I would call this a late transition. Okay, and late transition, also known as a clockwise rotation. Another thing that's pointing to this sort of anteroseptal infarct. So let's take this all together. Okay, now we have a regular atrial rhythm at a rate of 84 beats per minute in sinus rhythm. What does that tell you? That tells you that you're dealing with a normal sinus rhythm. Okay, now it's a normal sinus rhythm, but it is with a second degree AV block Mobitz type 2. Okay, I want you to notice that you can have normal sinus rhythm in the setting of an AV block. Okay, most books will not mention that. All right, they'll kind of skip over and they kind of separate the rhythms and call that, but I want you to notice that we have a normal sinus rhythm in a second degree AV block, Mobitz type 2. You have left atrial enlargement. Okay, we said that we have a complete right bundle branch block pattern. Okay, and then we have an anteroseptal infarct. Okay, and this is likely an acute, okay, because we saw that ST elevation associated with QAs, and obviously why I say that also is because I know that prior to this EKG, the patient only had a normal sinus rhythm. No block, no enlargement, okay, but this was taken a few years earlier, and he may have been lost to follow-up, or there haven't been a reason to get one in between there. Okay, so we have a 67-year-old male farmer presenting with substernal chest pain, worsened with exertional, okay, actually relieved with rest. Nitro helped the pain in the emergency department. This is typical anginal chest pain. Okay, troponins were elevated, and the patient did have an LAD infarct. Okay, so this EKG shows normal sinus rhythm with a second degree AV block, Mobitz type 2, left atrial enlargement, complete right bundle branch block pattern, and an anteroseptal infarct. Okay, and this is likely an acute event, as we saw here. All right, well, that's the end of this EKG of the week. I hope you learned something. Welcome to the EKG Guy if this is your first time. I'm glad you could join us this week. So this week we have a 68-year-old obese male farmer from Minnesota with moderate aortic valve stenosis. He presents with this EKG to us. And so what I want you to do is try to go through these things here over on the right, okay, to make your way through the EKG. To your first time, we'll go through this all so you'll understand our approach and then make a final interpretation. When you're ready, restart the video and we'll go through this together. Alright, so hopefully you had a chance to go through that. Now let's walk through this patient's presentation. So a 68-year-old obese male farmer from Minnesota presenting with moderate aortic valve stenosis in this EKG. Okay, so what we have to look here and what we normally do is start with the regularity. Okay, in the regularity, we want to find waves or intervals that are consistent throughout to call it a regular rhythm. Okay, so some of the best leads to look at are these rhythm strips down here. In this case, I would probably use V5 because you can see these R waves here. So from one R wave to the next is called the R to R interval. And what we want to do is measure the R to R interval. So here's the next R wave. So from that one that follows to this one. Okay, here's another R wave to this. So these are all R to R intervals. Okay, and if you were to measure all these out, you would see that these intervals are quite consistent. And because of that, we would in fact call this a regular rhythm. Okay, now if they weren't consistent throughout those intervals, then we would call it irregular rhythm, and then we would have to then look if there is any regularity to it or not, but we won't get into that here as this is a regular rhythm. So a regular rhythm, and we use that because there's multiple ways that we can find the rate. Now, one way you can find the rate for both regular and irregular rhythms, and I would recommend if you just want to have one way of finding the rate, is by knowing that from beginning of our standard 12 lead, so from here all the way to the end, represents 10 seconds in duration. If you multiply that by 6 is 60 seconds, which is 1 minute, okay? And what we want to do is count the complexes going across, multiply by 6, and you'll get an estimate of the rate in beats per minute. Okay, and you can either use this with P waves, or you can use it with the QRS complexes or T waves, and you would use the P waves for finding the atrial rate. If you want the ventricular rate, which we'll use here, we will use the QRS complexes or T waves, okay, and I would use the QRS complexes here. So let's go ahead and find that. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. And what you would do is put that 22 here, and you would multiply 22 times 6, okay? And so you would do 22, let's just do this here. So 1 is 13, so 132 is our close estimate here. Okay, so our estimate that we got from that, 22 times 6, hopefully is 132 beats per minute, if I did that math correctly. Okay. And that's an estimate of the rate. So you're again counting the complexes and multiplying by 6 because there's each is 10 seconds, the strip that we see here, and getting an estimate of the rate in beats per minute. Okay. Now we always want to know how to find the rate. You know, it's easy to rely on the machine, but as someone that looks at EKGs quite a bit, you'll often see that the machine is not always correct and will typically only give you the ventricular rate, at least here at our system here at Mayo Clinic, but yours may give the atrial rate. It's hard for the system to pick up P waves, so that's why it's often not given. So another way, because we have a regular rhythm, we can find a QRS complex that falls on one of those thick lines, okay? So let's see if we can spot one here. There's one maybe close to that here, okay? So notice that this is falling close to it, and we spot another R wave, which is right there, okay? And count the number of thick lines between it. So 1, 2, okay, so a little more than 2, and you would do 300 over 2, which is 150 beats per minute, okay, and then 300 over 3 is 100 beats per minute, okay, so I'm taking 300 as the constant, and then in here I'm putting the 2, and 3 would be this one here, but it's much closer to this, okay, so closer to the 150. So if it was between these two ranges, it'd be closer to that. Okay, we got 132 up here, so as you can see, that's closer. Okay, now another way, because we're noticing this is a fast rhythm, is by, instead of using that 300, what you would do is use 1500 and divide by the number of the small boxes. So you could do 1500 divided by from here until there, so maybe it's about 12, and then I'm not going to do the math, but hopefully it comes out to something near that. All right, so this approach where we're doing this division, okay, is something you can only use for regular rhythms. So I just want you to be aware of that. With the faster rhythms or faster rates, we tend to use that 1500 to be a little more accurate. Okay, so those are a few ways to find the rate. Now the actual rate that the machine gave us was 131. Okay, so I'll just put that here, and you can see that we are quite close with that first one. All right, if you want to know one way to find it, I would use that initial approach that we used there. All right. So let's move on here, okay? So next we have to look at the rhythm origin, okay? In this case, I like to start, so we're pretty much here's our, this is why and you'll see why I use this approach, okay? So here's the right atrium, left atrium, right ventricle, left ventricle. So I'm now asking myself, where is this rhythm that we're looking at originating from? Is it coming from down here in the ventricles? Okay, is it coming from somewhere here in the AV junction, or is it coming from somewhere up in the atria? Okay, so those are the main ones I'm asking. I start kind of from the bottom up, and I ask, are there any wide QRS complexes here? Meaning, is the duration of our QRS complex, so from here to here, wide, meaning is it at least 120 milliseconds or longer, okay? And if you look at our QRS complexes here, they're smaller than the 3 small boxes, so they're actually normal, okay? Meaning that we have something probably originating from above the ventricles, so that we don't have any intraventricular conduction delay that we'll talk about later, okay? Next, I ask myself, is it coming from the AV node, all right? Meaning that are there no P waves preceding our QRS complexes, or are they? And if there are P waves, are they coming at constant intervals throughout? So here you'll notice our P waves are these ones here. Notice that they're all coming at the same distance before our QRS complex, okay? So take a look at that here. So I'll underline these so you can see it a little more clear. Okay, so all these are pretty much the same, okay? Meaning that we have P waves proceeding, so that means we don't have a rhythm originating from just this area or down here. We either have something originating from the sinus node that sits up here, or from some ectopic focus here in the atria, okay? So we have some sort of atrial rhythm, whether from the sinus node or not, okay? So now we have to ask ourselves, do we have sinus rhythm present, okay? So is sinus rhythm present? Something very important, and I think often, taken for granted and not really understanding why we do have that. So let's try to understand. It's all you'll see as our teaching progresses. The goal is for you to understand why you see what you see on the EKG all the time, okay? So here's the right atrium, left atrium, right ventricle, and left ventricle, okay? And you'll always hear me harp on that because so many of those introductory books, whether it's Dubin's or Thaler's, and all those are quite insufficient, right? They won't help you to approach an EKG. They won't help you with patient management. And ultimately, they'll leave you feeling inadequate in patient care, especially when you're presented EKG in real life, okay? And that's why that was my struggle, and that's why I've developed this course. That's why I walk through these with you all the time, is because I don't think they're good enough. They serve a very introductory purpose. But yes, I can keep going on and on, but we won't get into that. All right. So let's understand why these rhythms, whether or not this is sinus rhythm. So sinus node sits up here, okay? And what you want to know is that from the sinus node, you have an AV node, okay? Also in the right atrium, you have a Bachmann bundle that comes to the left side. From this AV node, you have a His bundle, a right bundle branch that depolarizes the right side of the ventricle, the right ventricle. And then we have a left bundle branch that subdivides into a left anterior and posterior fascicle. From there, we have our ventricular Purkinje fibers that the impulse spreads from myocardial cell to myocardial cell and so forth. So that's how it works. Now, when we are asking, is sinus rhythm present, we're really just focusing on what's going on up here in the atria, okay? So we said P waves are present, so that means that we may have a sinus rhythm present, or meaning when we say that, we're saying that the rhythm is originating from the sinus node. And that's our question here. What is the rhythm origin? So what I want you to do is imagine this here. Here's our right atrium where our sinus node is present, this up here, okay? And now let's superimpose this on here, okay? So again, we'll put our sinus node up in this area, and notice that the impulse is moving in this direction, okay? Because it's moving in that direction, imagine it going like this, okay? Now again, we're only outlining this area here, okay? And I'm not mentioning this, or this, okay? So that's what I'm focusing on there. And from there, we have to notice that the normal P wave axis in sinus rhythm is between 0 degrees and positive 75 degrees. So this region here, okay? And as you can see, our vector is heading in that direction. And now we want to know what leads sit in those regions, okay? So we know that lead 1 sits here, the positive end. We have lead AVF down here. Lead 2 is at positive 60 degrees. All right. Lead 3 is over here. And then we have V4, V5, V6. AVR is here, and so forth. Okay, so that's how it looks. And notice that that red arrow, this impulse as it's coming from the sinus node, is heading in this direction, meaning that these leads should see upright P waves. And these leads, AVR, should see a negative P wave there. So hopefully that makes sense. So let's look at if we have sinus rhythm present. So what you want to do is look at those leads. So let's look at lead 1. Here's lead 1. Notice that our P waves here in lead 2, if you look up, they are upright, okay, almost blended here with our T waves, but pretty flat T waves. So they are upright there. You can see they're upright, especially in lead 2. Okay, if you look down here, that's the lead that we were showing all those P waves. So again, these P waves are upright. If you look at lead 3, same thing here. Okay, so upright P waves, but notice lead 3 is over here, so you may not always see it here. All right, and then we wanted to look over, and here's AVF. You can see upright P waves there. Over in these lateral leads, here's a P wave in V4, V5, and V6, and then AVR, which is this lead here. So if you look straight up, you can see that these P waves here are negative. Okay, so what this indicates is sinus rhythm is present. So we just spent a lot of time looking at that, but hopefully that makes sense. So we do have sinus rhythm present, okay? Now that doesn't exclude that we don't have a rhythm originating close to the sinus node from the atria, but generally speaking, that's what we want to see, okay? So hopefully that makes sense, and that's the approach you should take, because if you can understand why we're looking for those, what we're looking for in sinus rhythm, not just upright P waves in lead 2, which, you know, often case can work, but understanding why you see that is important, okay? All right, so that's the rhythm here so far is a regular rhythm, okay? We have a rate of about 130 beats per minute, so fast rate, and then we have a sinus origin, okay? So hopefully that makes sense. Now let's move on to the ventricular axis, okay? Ventricular axis, I know some of you are wondering what we use here at Mayo. We tend to use negative 30 degrees and positive 110 degrees, meaning that this area here is considered normal ventricular axis. Remember, we talked about the P wave axis in this from the sinus node between 0 and positive 75. In the ventricles, it's a little different, okay? So that tends to be the normal axis. Let me just spread this one out a little more so it's a little more similar. So about that region there, okay? And then what we have up here is more of a left axis deviation and right axis deviation or shift, and this would be a northwest axis. Here's north, here's west, so that's where we get that northwest, okay? Not many things hang out there, but VT, or ventricular tachycardia, is something we can see up there, okay? All right, so this is what we have here. And so this is in adults. Remember, in children, they have more of the right ventricles dominating, especially towards the end of gestation at around 34 to 40 weeks and up to that first week of birth. They have more of a rightward shift, the right ventricles dominating, but eventually with age, we tend to shift more leftward, okay? That way, if you have someone that has more of a left ventricular hypertrophy or hypertension and you're seeing more of a rightward shift, that should alarm you. Maybe there's something going on. Maybe there's strain from a PE or something that may be causing the right ventricle to have such a dominating force there. Okay, there may be a bundle branch block that is also present. So let's look here. So here we have lead 1 and lead AVF. And we say lead 1 because lead 1 sits here and AVF sits down there. Okay, so let's draw it out here so it's clean. So lead 1 and AVF. There are many ways that you can find the axis, but we will use these because it's quite simple, okay? And let's look here. So what we want to do is look at these leads that we've pointed out. And we want to look, are they mostly positive or are they mostly negative, okay? So what you want to look here is we'll look at lead 1, okay? So lead 1 up here, and we're pretty much taking this baseline, oops, it's a little above that actually. I've kind of showed the ST segment, but here it's a little higher, okay, from there. And you're measuring the difference, pretty much, if you have this complex, between this and this, okay? Is it mostly positive, meaning above the baseline, or mostly negative, okay? In this case, it seems like it's almost isoelectric, meaning that it's almost the same above and below the plane, okay? Maybe a little more negative or so, but I would say mostly isoelectric. So if it was mostly positive, it would go towards the positive end of lead 1. If it was negative, it'd go towards away from that positive end, okay? But because it's isoelectric, it kind of falls on this line. So we'll leave it there. So hopefully that makes sense. Now we also mentioned another lead here, and that lead here was AVF. So AVF down here, again, we're going to be taking this area here. So you're taking this baseline. Notice you have this small Q wave there, but mostly positive. So if I were to draw that out, just so you can kind of see that, so what I'm seeing here is a P wave, a small dip for a Q wave, mostly positive, and then something like that. So we're looking at this, mostly that's a small negative, but most of this is positive, okay? So in other words, we would go towards the positive end of AVF, okay? So towards the positive end, which would mean that our axis lies somewhere here, okay? Now another lead that we could look at is lead 2, okay? Or we can look at all these leads pretty much. So here's lead 2 sits here at positive 60 degrees. Okay, lead 3 over here at positive 120 degrees. So if you look at lead 3, it's positive. So we'd go towards the positive end of this. If you look at lead 2, it's also positive, but maybe not as much positive as lead 3. So maybe the axis lies somewhere in here. Okay. In fact, the axis was positive 99 degrees. Okay, so positive 99 degrees. So we said this is 110. The axis may be somewhere there. Okay, so positive 99 degrees, still within our normal axis. So I'd say normal, but with the 68-year-old obese male, maybe a rightward shift in the axis. Okay. So it was positive 99 degrees. So this is where you have to kind of put your clinical suspicion and everything when you're making clinical decisions, taking all this into account. Okay. Alrighty. So next, let's look at atrial conduction. This is where we're looking at the P waves. Okay. Remember, my approach here is so we don't miss anything. Okay, and this approach that we've been doing here is something I've created just because, you know, everyone has their own way of approaching, and some are better than others, but hopefully you just don't want to miss anything. And so this is something that I've used that's helped for me not to miss anything. And what I'm doing, just to give you an idea of why I do this, remember I said the atria, here's the right atrium, left atrium, right ventricle and left ventricle. I use this approach because I want to look at the atria. Are there any issues up here in the atria? Anything here in the AV junction, and then the ventricles. So you'll see that we look at the AV node or atria, AV, and IV. Okay, so let's start with the atria, and here I want to focus mostly on, are there any left atrial or right atrial abnormalities? Okay, and what we will see here is that these P waves here, okay, and so forth, do not show any enlargement. Okay, so we are not going to go into the details. We've done that in multiple other lessons. So there are no atrial abnormalities here. Okay, there's no enlargement of either the right or left atrium here. Next, we want to look at AV conduction. And AV conduction, so if you imagine our complexes like here, we've looked at the P wave so far, so we can check that off. Now I'm looking in here. So in this region here, the PR interval, okay, are there any issues there that you see? Well, the PR interval here, which is, as I measured here, from this to this, okay, can suggest that we have a slowing of conduction. So if you look here, you want to find a P wave, so notice that the QRS complex sits there, and the P wave just about there, okay? And that one big box is 200 milliseconds, which is kind of the upper limit of normal for an adult patient. So this was actually measured by the machine at 206 milliseconds. So in that case, we would call this delayed conduction through the AV node. Okay, so that's one thing to note. And because you see that consistently throughout, this is representative of a first-degree AV block. Okay, no drop beats, so we don't have to mention anything there, but hopefully that makes sense. So this is a first-degree AV block. So we've looked at conduction through here as well. So far we've looked at the atria, the AV node, and now I want to look here at the QRS complexes as well as the T wave. Okay, an IV conduction, we're simply looking at, is this prolonged or not? And earlier I told you that it wasn't prolonged. It was at 92 milliseconds by the machine. So there is no conduction delay within the ventricle, okay, that you may see with a bundle branch block or something else there. So we won't mention anything else in this case, okay? So as you can see, we went from the atria, AV node, and now the ventricles, okay? And don't worry, we are not missing any of the wave segments or abnormalities that we'll talk about shortly. So now we get to the waveforms, okay? And now we're starting to break this down into, and just so you're aware, the normal is 70 to 110 milliseconds of IV conduction. So that's why there's no issues there. So let's look at the PR segment. Okay, so again, we talked about the PR interval. The PR segment's at the end of the P wave up until this point here. And here we want to see, is it elevated or depressed at all? Okay, meaning is it above the baseline, elevated, or depressed? And if you look here, we're looking at this area here. It's not really so much. You can see kind of this, how it goes like that. And that may be artifact, a motion artifact. Is there on the limb leads, okay? Whereas you can see V1 is pretty flat as the patient's on chest, okay? So I wouldn't say that there is any PR elevation or depression that's significant here or alarming, okay? When we look at next is looking at Q waves. So Q wave, there's no Q wave here, but a Q wave would be something like this. So it'd be this first negative deflection. Remember, this is an S wave, this is an R wave, this is an R wave, okay? So this is the first negative deflection here of the QRS complex that comes before an R wave, okay? And so leads that we can see Q waves developing, okay, are here in lead 3. You can see that as these small ones, lead 2, and maybe AVF, okay? Those are the main ones that we can see it. So oops, wrong spot. So the Q waves, let's just erase this here. We mentioned in 2, 3, AVF. Okay, so 2 is here, AVF is here, 3 is here. Remember, these are the inferior limb leads. Okay, now in the ST segment, is this portion here. Okay, from the end, from the J point or end of our QRS complex up until the T wave. Is it elevated or depressed? Okay, this is where we start to see ischemic changes. So when you look here, notice that this is elevated. Okay, same thing here. There's J point elevation, and J point is simply this area here. That's the J point. So it's elevated in those leads, okay? And then you can see some depression specifically here. Notice in lead AVL as well as lead 1, okay? And you also maybe see some depression here in V2 and V3 as well, okay? So when we talk about here, we can put ST elevation that we see in 2, 3, and AVF, okay? And it seems to be most prominent in leads 3 and then AVF in lead 2. So 3 is the most prominent, and that is helpful when we try to localize these areas of infarct, okay? And that's what the interventional cardiologist will try to do before intervening on a vessel. So 3, and then we mentioned some ST depression, so let's just write that there, ST depression, and 1 and AVL, and then also V2 and V3 we mentioned as well, okay? Maybe in V4 as well slightly, but anyways. And the other thing we want to mention here is any T-wave abnormalities. Nothing significant all with the ST segment, so we'll get to that shortly. So QT interval, just so you're aware, is from the beginning of our QRS complex all the way to the end of the T wave. We use something called the QTC, which is corrected for heart rate, okay? Because heart rate has a big influence, and this was 528 milliseconds, okay? So this is prolonged in a male. Normally in a male is less than 440 milliseconds, and females 460. Not until around 500 do we get alarmed, but this is certainly prolonged, 528. Okay. So let's move on to, is there anything else present here that we've missed so far? Well, there is one thing that I want to mention, and that is that the voltage actually throughout the EKG is quite low. Now, normal voltage, and that's like the amplitude, meaning how high and low are these complexes. So if I look at this from top to bottom, in the precordial leads, which are V1 to V6, you want it to be at least 10 millimeters. So less than 10 millimeters in amplitude is considered low QRS voltage in those leads. In the limb leads, which are these here, so these are the precordial on the right. So precordial, these are limb. Another word for precordial is the chest leads. Limb leads is less than 5 millimeters. Okay, well, in the limb leads, you can kind of see here that it's kind of just making it, but in the precordial leads, it's low, okay? And so low precordial QRS voltage, okay, is one thing to note. Now I just want to end here before, I know we've gone through so much in this, but as you can see, the EKG really holds a lot, okay? And I might start to discuss some of the things that we're doing here with artificial intelligence, that it's showing more than the eye can even glean on initial glance, which is quite remarkable. We have a few papers submitted, some that you may have seen in some of the prominent journals, but the last two things are transitional zone and the R-wave progression. And this is where we focus here on the precordial leads. Okay, and here we're looking first at R-wave progression. Okay, and these chest leads or precordial leads are placed on the chest, so it really depends who's placing them, how they're placed, and so forth. And what you want to see in this case is that the initial R-wave should increase in amplitude. Okay, so normal R-wave progression is increased R-wave amplitude from V1 to V5, or an increase in the R wave to S wave ratio. Okay, R wave to S wave. So here's the R to S. Okay, and you want to see this to go up and this to eventually go down, or at least smaller in amplitude. And as you can see here, we have the R waves that progress, and slowly these S waves have decreased. So I would say this is normal R wave progression, nothing concerning there at this point with that. Now, in terms of transitional zone, this is where we go from mostly negative complexes to positive complexes as we progress across the precordium. So again, in these precordial leads, and notice that this seems maybe mostly positive actually there, but it is actually negative because we, again, this took a while to actually get, but you want to use that initial wave, and that initial one there seems like a Q wave, okay? So I would say mostly negative there, still mostly negative here, still mostly negative there, but then you see the transition here to this R wave being more so. In normal transition, so this is normal, is between V3 and V4. If it comes before V3, meaning that these complexes became positive before V3. Okay, so imagine if this was more positive, we would call that an early transition, or a counterclockwise. If it was after, we would call it a clockwise or late transition. All right, so we're already going along here, so I don't want to take too much more of your time, because I know you have a lot of other things to do. So let's start to sum this up. So we have a regular rhythm, likely originating from the sinus node and at a rate of 132. Okay, so just that alone should suggest this is sinus tachycardia. Okay, and then we mentioned a rightward axis shift. Okay, so we could just note here right axis shift, still within normal, but we can say that in this adult patient that may be something for us to keep in mind. We notice that there's no atrial conduction abnormalities, but there's delayed conduction here that was consistent and prolonged at the PR interval at 206 milliseconds. So we have sinus tachycardia with a first degree AV block, okay? Normal IV conduction. And then we did mention some Q waves that were developing there in those inferior leads, these ones here. Okay, as well as ST elevation, and we see reciprocal changes in leads 1 and AVL. Okay, that's going on there. You also see some depression, maybe in V1, but mostly in V2 and V3. Okay, and what this actually points to is that this patient likely has an inferior MI, myocardial infarction, presumably acute actually. Okay, you have ST elevation going on in the setting of developing Q waves, okay, with reciprocal changes. So I likely say this is an inferior MI. That is acute, but I'd also say this is probably a posteral inferior MI. Okay, and I'm just looking at this here, that these are likely suggesting that there is actually posterior involvement. Okay, and what I would get from that, or glean, that we likely have an RCA infarct, okay, that's extending to the posterior descending artery, okay, as a result, because in this patient it may actually be right coronary or right-sided dominant. Okay, so as you can see, I'm trying to predict where the interventional cardiologist may intervene, and so it's likely right-sided involvement. The patient may be right-sided dominant because you see the posterior descending artery involved, which is supplied by the RCA in the right dominant patients, and a little more advanced stuff, but that's kind of what we're getting from all this. The other thing is the low QRS voltage. Okay, specifically in the precordial. We said that it didn't meet it there in the limb leads. Okay, so in all, we have sinus tachycardia with a first degree AV block with a right axis shift. Okay, posterior inferior MI, that's likely acute, and this low QRS voltage. Okay, when compared to the previous one, the patient was in normal sinus rhythm. Okay, so this is a complete change. So we have loss of voltage, we have a new AV block, we have a fast rhythm. Okay, and one thing to note, when you have these RCA infarcts, that's the one that's supplying that AV node, and maybe a result of that now new first degree AV block. Okay, sinus tachycardia, maybe the patient's having chest pain or something that is contributing to this as well. So a lot going on here, and hopefully that made sense. I will leave you there with that, and I will see you next week. And thanks for joining us this week. I hope you have a wonderful week, and I hope you learned something. Welcome to the EKG Guy. If this is your first time, I'm glad you could join us with this week's EKG of the week. And here we have a 72-year-old male with sinus node dysfunction presenting with this EKG. So what I'd like to do is go through these here things on the right, okay? Try to address each one of these issues or aspects of the EKG, and then make a final interpretation. Once you're finished, restart the video and we'll go through it together. Alright, so hopefully you get a chance to go through the EKG yourself. And now let's walk through each aspect of it here so we're not missing anything. And this is the approach we've been using and we'll continue to use unless we find something else that works a little better. But first thing we want to do is look at the regularity of the rhythm. Okay, and in this case we want the regularities, meaning the distance or time between intervals, to be consistent for it to be regular. Okay, if it's not, then we would call that an irregular rhythm, and then from there we'd have to find out if there is any regularity to that irregularity. Okay, in which case it would be a regularly irregular rhythm, and or if it was always irregular, such as an atrial fibrillation, which is an irregularly irregular rhythm. Okay, so let's look here to see what we mean. So what we look here, and we want to use these rhythm strips down here. This is a standard 12-lead EKG, and these bottom leads here are 3 rhythm strips, okay? And what we want to look for are intervals being consistent throughout. We typically look for these R waves here, okay? These are these positive deflections here, okay? And these R waves, you can see that there's about 6 there. From one R wave to the next, we call that an R to R interval. And as you can see, here's the next R to R interval, and then one that follows, and so forth. And these are all different R to R intervals. If they're the same throughout, we call that a regular rhythm. And in this case, the distance between them is quite regular. So this is in fact a regular rhythm. Okay, so that's the regularity. Next we look at the rate. And we look at the regularity first because then it dictates some ways that we can find the rate. Okay, with irregular rhythms, we're more limited in the ways that we can find it. But now that we have a regular rhythm, what we can do is, knowing that from beginning to end is 10 seconds, if you multiply that by 6, that's 60 seconds, or 1 minute. We can then count the complexes, multiply by 6, and get an estimate of the rate in beats per minute. Okay, so what we can do this with either the atrial rate by using the P waves or the ventricular rate by using the QRS or T waves. So in this case, we can do that here by saying 1, 2, 3, 4, 5, 6, okay, meaning that there's 6 QRS complexes there, so the estimate rate should be about 36 beats per minute. So we got 36 beats per minute, okay. Another way that you can do this, because we're dealing with a regular rhythm, is by finding an R wave or one of the complexes that falls on one of those thick lines. So in this case, we can do this one here. Notice it's on one of the thick lines, and the next one that falls almost halfway between those thick lines of these boxes. Okay, and we're going to count the number of these dark lines between it. So 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's about 8.5. So what you would do from that point is then take 300. Okay, this is a number that we won't get into here, but it's pretty much the big box is over 1 minute, and you do 300 divided by the number of thick lines that we found to be as 8.5, okay, between the R waves or within that R to R interval. And if you were to do this, you'd get an estimate of about 35 beats per minute. Okay, it was like 35.2 or 35.3 when I calculated it earlier. So that's an estimate of the rate there, and as you can see, close to our 36. Now the actual rate that the machine gave us here was 34 beats per minute. Okay, so the machine, I'll just put right here. So as you can see, quite close, 34 beats per minute there. All right, let's move on here to the next aspect, and that's the rhythm origin. So where is this rhythm actually originating from in the heart? That's what we're asking here when we talk about the rhythm origin. Okay. Now one way that we've been doing is by looking at these QRS complexes. If they're wide, that may suggest either aberrancy, okay, some intraventricular conduction delay, or that the rhythm's not originating from it may be originating from the ventricles. So in this case, we have narrow QRS complexes, okay? So then we look for P waves that are preceding these complexes, okay? And as you can see here throughout, there are not any clear P waves, okay? Maybe some fibrillation, but no P waves in lead 2 or V1, which are the best leads that will show it, okay? This you may think is a P wave, but if you look up, there's nothing there. So I would say there are no clear P waves here. So now we're dealing with a rhythm that is narrow, has narrow QRS complexes, okay, and it has no preceding P waves. So if we draw out our heart here, okay, this being our right atrium, left atrium, right ventricle and left ventricle, our atria up here that produce the P wave, and we're saying there's no P wave present, so it's not coming from the atria. And then we have normal QRS complexes, which are from the ventricles, okay, so likely not originating from here, okay, and therefore it must be originating from somewhere between where that AV node or junctional rhythm takes place, okay. So that is likely where this complex is originating from, okay, so we'll call this likely coming from the AV junction. Hopefully that makes sense there, okay. Now let's find the ventricular axis. So let me just erase this here. The ventricular axis, and we're dealing with an adult patient, right, a 72-year-old male. So normal ventricular axis that we use is between -30 and positive 110 degrees. I mean that this is all normal axis in this adult patient, okay? This is considered over here left axis deviation in this region, This would be right axis deviation, okay? And this region here we would call a northwest axis, because this is north and this is west, so that's where you get that northwest, okay? Or a superior rightward, because this is rightward and up, so superior rightward axis, or no man's land. So a number of different things that you can call this. So again, we said normalize in this region here. Remember that leads 1 sits here, lead AVF sits here. Okay, that's the positive ends of those leads. So now let's find the axis here. Okay, where does this ventricular axis, so the QRS complexes are what we're looking at because it's ventricular. Okay, so let's look here. We said that lead 1 is here, lead AVF is here. These are the best leads to look at, especially when you're just starting off with trying to find the axis. There's a number of ways you could find it, and some that are a lot faster, but we will use this one here. Okay, so here's lead 1 and here's lead AVF. Okay, so not many complexes, but here's our QRS complex, and you can see that it's mostly positive. Because of that, we'll go towards the positive end of lead 1, okay, in that direction. If we look at AVF, if you were to look at this one here, you might say this is mostly negative because that negative portion is more negative. So this is the positive end of AVF. We're going to head away from it, okay? So that puts us in this region here, okay? Somewhere within here, as you can see. And notice that left axis deviation takes up some of this, and so does that normal area. So we have to figure out, are we over here with a left axis shift, or are we over in this region, okay? So how do we do that? Well, what's nice is that we have a lead here called lead 2, okay, that sits at positive 60 degrees, and actually perpendicular to that lead is a lead that comes this way here, and that comes at negative 30 degrees, as you can see, just like this one, okay? And what that means is if lead 2 is positive, we'll go towards the positive end of lead 2. If it's negative, it'll go away from it. So negative would put us in this region, and positive would put us over here. So if we look at lead 2, which is this one here, you can see that this complex here is mostly positive. Okay, you can see that. So because it's mostly positive, we're in this region here, which means we have a normal ventricular axis. Okay, so this is a normal ventricular axis, and the machine actually gave us negative 17 degrees. Okay, so where does negative 17 degrees sit? Well, if we erase this here, okay, here's that negative 30 degrees. Negative 17 would be about right here, where we were expecting it. Okay, so hopefully that makes sense. So this is a normal ventricular axis in this adult patient. Next, we have atrial conduction. Okay, this is where I'd like to focus on, are there any atrial enlargement abnormalities within the atria? Okay, either the right or left atria. And here, we don't have any P waves that we made out. Okay, now P waves may be buried within the QRS complex, which may be the case here. So in this case, we can't comment on that, okay? Because when we look at atrial enlargement, those specificities that were laid out have to do with making sure that the sinus rhythm is present, okay? And if we're saying that the rhythm's not originating from the sinus node, then we actually can't comment on right or left atrial enlargement, okay? So that's one thing to keep in mind. All right, so again, what we're looking at here are these complexes. Here's a normal complex. This is our P wave, QRS complex, and T wave. Okay, here's our P wave that we said was not present, so we said nothing to comment on atrial conduction. Next, we look at AV conduction, which is atrioventricular. Remember, that's from our PR interval, which is from the beginning of our P wave to the beginning of our QRS complex. That's our PR interval. And because we said that there's no P wave present, we can't comment on that here. Okay, if it's buried in the QRS complex, you may see a short PR interval, but in this case, we won't mention that. So nothing to comment here on AV conduction. Just a side note, remember that the PR segment is from here to here. Okay, so meaning that the PR interval equals the P wave plus the PR segment. Okay. Next, let's look at IV conduction, or intraventricular conduction. With intraventricular conduction, we're looking pretty much at the width of the QRS complexes. And we pretty much mentioned earlier that they seemed narrow. And what do we mean by that? So from the beginning to the end of our QRS complex. That's the width we're looking for. Normal is between 70 and 110 milliseconds, okay? And some are saying 120. Here at Mayo Clinic, we use 70 to 110. Once you hit 120 or 3 small boxes, we consider that prolonged, okay? So we're going to be sticking to that criteria we use here. Okay, so the QRS complex in this case was actually normal at 96 milliseconds, okay? So normal IV conduction, the QRS interval was 96 milliseconds, which is within that normal limit, okay? Next, we want to look at the waveforms, and that's that next portion there. Okay, so let's start looking at that. We'll just erase some of this here, okay, and then we'll move on to that, okay? So hopefully this is making sense. Again, we're finding a lot of different things, and as you can see that really going through an EKG, you have to have some sort of systematic approach, or you'll, more often than not miss something, okay? And we don't want to miss anything that's crucial, okay, especially when it affects patient care. And that's why you can see we always do this systematic approach as we move through the EKG. Okay, so now let's move on, we said, to these waveforms. So first we want to look at the PR segment. So remember, if we just draw this out, here's our P wave, our QRS complex, that represents actually an RS complex, and this is our T wave. The PR segment is we're looking from here to here. We're asking ourselves, is it elevated or is it depressed? Okay, and because we said that there's no P wave, we don't really have much commenting on the PR segment. Next, we want to look at the QRS complex, which is this one here, and we're looking for any abnormal or pathologic or significant Q waves that may represent a prior infarct, and sometimes an ongoing one, okay, so, or acute injury. So what we see here actually are a Q wave actually in V1, okay, in V2, and maybe V3, you may see this initial portion that may be a small R wave, but certainly in V1 for sure, we see that, okay, so V1 is one that we should keep on. So I'm just going to comment on that, plus or minus V2 to V3, okay? It's hard to always get that, but V1 for sure, and you can see it down here too in lead V1, okay, in each lead. So all of these are deep Q waves that are not normal, okay, and you can kind of almost see, we'll get to the loss of R wave progression throughout the precordial leads shortly, but something to keep in mind there. All right, next we're looking at the ST segments, okay? So ST segment is this portion here from the end of our QRS complex up to the beginning of our T wave. Is there any elevation or depression, we're asking ourselves, okay? In this case here, okay, there's not much ST segment elevation or depression, okay? Not something that I would certainly comment on. You see a little issue here at the end in the complexes, but nothing significant, and that isn't depression or elevation that's going on there. So really not much to comment on here that would be significant or stand out, at least that would change our management. Next we look at the QTC interval, and what do I mean by that? That is from the beginning of our QRS complex all the way to the end of our T wave. This is the QT interval. You'll notice there's a C there, and C stands for corrected, and that corrects for heart rate, okay? Most of the machines use the Bazet formula, which accounts for heart rate. There's many other formulas, but in this case, this male patient here, okay, normal should be less than 440 milliseconds. In this patient here, it was 439 milliseconds, okay? So again, within normal limits for this male, all right? Now normally not until around 500 milliseconds do we get a little concerned so much, and sometimes the machine will give us an alert, whether if we're in the hospital of a patient that is having a more prolonged QTC interval, because this is could put patients at risk for torsades, okay? Which is could be a life-threatening arrhythmia, okay, or ventricular arrhythmias. All right, so let's move on to the last few things. And these last two things, first of all, is there anything else that we're missing here? Okay, I think those are about the main things here. Some other things we should note are the R wave progression, okay, and these have to do with the precordial leads, these last two things, the R wave progression and the transitional zone. So let's look at R wave progression. And what you want to see with R wave progression is a slow increase. If I can draw this up, it's not going to be the best, so let's try it again. Yeah, so this is going to be hard, but anyways, you want to see a steady increase in the R wave as you go across the precordial leads, okay, and actually a decrease in the S waves. So these are the S waves here, okay. They should actually go down. Obviously, the drawing is not going to be fit, and I'm not going to waste your time trying to master something that will take me forever to do. So the R wave should increase as we go from V1 to V5. Okay, so from V1, which is this one here, V2, V3, V4, V5, the R waves, which are absent here, maybe slight one there, slightly there, but then you can start to see them more here and here, okay? But they're pretty much absent in V2 to V3, okay? Because we don't really see those in those leads, we would call that a poor R wave progression. All right, so hopefully that makes sense. And that can signify an anteroseptal infarct or something when you have those poor anterior forces that may be going on there. Okay, so we will get to that shortly. Next is the transitional zone, and this is where you're going from mostly negative complexes to mostly positive complexes, the QRS complexes, in the precordial leads. So you'll notice here that these are mostly negative, mostly negative, mostly negative, still mostly negative, and maybe here you start to get almost an isoelectric or maybe slightly positive. So the transitional zone here is right around V5, I would say, but normal is between V3 and V4. So between V3 and V4, you should see that change from being mostly negative to mostly positive, but we don't see it. We see it occurring later, and because of that, we call that a late transition, okay? Or we call that a clockwise rotation. Okay, so clockwise rotation because it's occurring later. Both mean the same thing. All right, and those can both suggest that we have poor anterior forces, and most of it's coming from the left side. So let's review what we have here. We have a regular rhythm, a rate around 36 beats per minute, okay, so slower, at the AV junction, likely origin, and that should tell you that we're dealing with junctional bradycardia. Okay, so, and we'll get to this shortly, but this is junctional bradycardia as our underlying rhythm. Okay, the axis we said within the normal limits, okay, slightly left or shift, but physiologically normal in this adult patient. Atrial conduction is, we don't have anything to say, or AV conduction because we couldn't see any P waves there. IV conduction was normal, that in the intraventricular space. We had nothing on the PR segment or ST segment, but we did say these Q waves. Okay, and this likely suggests this poor R wave progression that we mentioned here, that late transition, those Q waves in these leads, okay, showing a really low forces in the anteroseptal region, likely suggesting a prior anteroseptal infarct. Okay, and this is actually what the patient had, okay, and we'll call this an old anteroseptal MI. We don't see any ST segment changes that would suggest it's more acute, and the T waves have kind of reverted back to normal. So hopefully that makes sense there. So an old anteroseptal infarct. Now we always want to compare to a prior EKG, and one thing to note on the prior one, it did show the anteroseptal MI, and it actually showed a junctional rhythm. So junctional rhythm on the other one. And it also showed the anteroseptal MI, which was likely suggesting an old one. Okay, so these are the new interpretation, these are the prior one. So I want to just go over a few things. Notice that we said junctional bradycardia here, junctional rhythm here. And what you need to know is that there's an intrinsic rate within different regions of the heart. So if we draw out our box diagram here, this being our right atrium, right ventricle, and left ventricle, We have our sinus node up here, has these internodal pathways in a Bachman bundle, comes to our AV node. We have our His bundle, splits into the right bundle branch, left bundle branch with the left anterior and posterior fascicle, and something like this. And what you want to note is that different regions, okay, and we'll kind of say that the atria have their own intrinsic rate, which includes the sinus node. So we'll say that the atria has a intrinsic rate between 60 and 100 beats per minute. Okay, so pretty much the sinus node and all this atria. This junctional, AV junctional region has a intrinsic rate between 40 and 60. Okay, and these are all estimates. There's more exact ones, but this is a good way to framework to keep in mind. And the ventricles have their own. The ventricles between 20 and 40 beats per minute. Okay, and this can sometimes help you to locate where that rhythm is originating from. So because in this case there was a regular rhythm, a rate that was slow with no P waves, we had an idea that this was coming likely from a junctional region, meaning that it would come from somewhere in this region. So let's see if we can erase some of this here. So because it's coming from somewhere in that region, you can sometimes see not only the QRS complexes that result as it heads downward, but also the retrograde. You may see inverted P waves as it goes away from those leads, in which case these inferior leads you may see upright P waves, okay, as it's going, or negative P waves, excuse me, as it moves away from the inferior leads down here. That's lead 3. Anyways, the main thing I want to talk to you about is the terminology of these junctional rhythms. So notice we said the atria and the sinus node have a rate in adults, okay, between 60 and 100 beats per minute. And then the AV junction, we're saying is between 40 and 60, and the ventricles 20 to 40. Let's focus on this one here, okay, because we said this is a junctional rhythm, and what the junctional rhythm means is that it has a rate between 40 and 60 beats per minute. Okay, when it's a bradycardia, it means it's less than that 40 beats per minute, and that's why we call this. So this is junctional bradycardia when you have a rhythm originating from the AV junction that's less than 40 beats per minute. Now, if the rate were between 60 and 100 beats per minute, this would equal a junctional and actually an accelerated junctional rhythm. Okay, so pretty much an accelerated junctional rhythm between 60 and 100. Now, if it was over 100 beats per minute, just like any other, we call that a junctional tachycardia. Okay, so just like this one in atria, over 100 is a tachycardic rate or fast rate over 100. Same thing with these junctional rhythms. So a junctional rhythm less than 40 beats per minute, that's why we have this junctional bradycardia. A junctional rhythm has that intrinsic rate between 40 and 60 beats per minute. When it goes between 60 and 100 beats per minute, we call that an accelerated junctional rhythm. And then when it goes over 100 beats per minute, we have junctional tachycardia. Okay, so it's just some nomenclature that is sometimes confusing and sometimes worth reviewing. All right, well, that's all we got for this week. So we have a junctional bradycardia and an old anteroseptal MI that was there from prior. Okay, I hope you learned something, and I look forward to seeing you next week. All right, have a wonderful week. Now, just to keep you in mind of our course material that we have available, so again, if you go to our website, www.ekg.md, okay, so this is our website, and what you'll notice is that if you go to the EKG course here, okay, you'll find stuff that's separate. So notice that we have a number of topics, practice material, lectures, a way for you to contribute, and this is the course here over here. So you'll notice we have over 300 videos or so, and that's more on YouTube. There's another 100, more than 100, about 200 videos that are available with the course. So those are separate videos, and this course is really designed to take you from a beginner to advanced interpreter. Okay, so completely separate from what you're getting online for free. Okay, these are course material that comes with it. So notice that you have a book Okay, and then you also have the pocket guide available, so you can choose which format. They are the same thing, both these book and the pocket guide, different formats. I really like this small one because you can keep it in your white coat if you're in the clinic or in your pocket, and it's really available on the go. Now with the book, you also get videos. So notice these are the videos, okay? And these are a video for every single page in that book. So it's over 30 hours of video. Now there's a number of practice material that I continue to upload there, okay? We'll have practice questions coming soon. So all of that's available. Again, this is separate from all the free material that you get already. Okay, so this is more high yield stuff. This is what we used to teach our technicians here and our students here at Mayo Clinic, and it's used now among many institutions. So check that out. Now, what it also includes are calipers. So yes, you get calipers with this course. Okay. I don't know anyone else that offers that, but you do get calipers. I think they're very helpful, and they can, if you know how to use them correctly, can help to identify different arrhythmias that are going on. Okay, and then you also get our pocket EKG reference. Okay, this was something we've put together as we were developing course for the fellows, and this is really nice. It has every code, as you saw earlier, laid out there. Very small pocket guide available. I had help with my colleague, Dr. Peter Noseworthy, who's the head of the EKG lab here at Mayo Clinic, in editing it. So this is something that we use and we've found very helpful. So go to the EKG course. You'll see examples of lectures, okay, why we developed this, okay. A lot of it came about from myself struggling with learning EKGs, having a father that was an interventional cardiologist and, still struggling. So my struggle is a struggle that I don't want you to have in learning them, okay. You can read all those introductory books, but honestly, they are not enough, okay, and you find yourself using other resources, which is part of the learning process. I wanted to expedite that process for you and make it less inefficient in pretty much what I struggled with going and learning through EKG. So again, from beginner to advanced level with this course, you get the book, the calipers, the coding reference, video access, okay? And now we're offering 25% off. 25% off. Put that code in on checkout and you'll have yourself 25% off that will it's pretty much covers the cost of what we use to print the material. So we don't really make much off it. It's more to help our learners grow and really be able to contribute to patient care. That's why we do this, and we love doing it. So thank you so much for your support. If you have any questions, just leave them below, and we're happy to answer them. All right, have a great day.